We're going to be talking about and interacting with each other around AI 2.0 in healthcare. And we're thinking about from pilots to practice, implementing AI in an everyday clinical workflow. I know from the briefing, this should be a very entertaining session because of the fact that we have very different representation here across it. So we kind of have some hospital folks. We have myself, who's worked in a hospital, works in the private industry, has worked for tech companies, and some different views, I think, on AI. And so really looking forward to this session. I think the key thing, too, for me is we were talking about pilots, right? So from pilot to practice. And one of the things that I learned from Johnson & Johnson when I got there is that we don't do pilots, we do test and learn, right? Because a lot of times if you're at a pilot, it fails to launch, right? So we've had so many, and I think that the healthcare system is infamous for this, right? Where we've got pilots that are doing really, really well all over the place. And then how do we scale them? I think that's something that we always struggle with. So really looking forward to the insights today so we could develop our own test and learn initiatives, or maybe it is pilots, and really move on past piloting to integration and to launching at a full scale. So again, we have Deepak. I've had an opportunity to work with Deepak for years. When we developed some of the HBAM stuff, and I don't want to say that too loudly, Deepak, because we might get jumped outside. So we'll leave it to that. And then we have Victoria, a recent, more of a closer friend of mine in recent days. We had the opportunity to develop a lot of these things. And Michaela, a new friend of mine, and stuff like that. So again, really looking forward. So what we're going to do is we're going to start off. Maybe I get each of you to do an introduction of yourself and really what brings you here today and what you're hoping to share. Yeah, we'll start with Deepak at the end.
Hello, everyone, and so happy to be here this morning. My name is Deepak Sharma. I'm the Vice President for Strategy and Organizational Performance at William Osler Health System here in Ontario, just over Brampton and Etobicoke. And so at Osler, lots going on, lots always going on in Brampton. So one of the fastest growing regions of Ontario, significant gap, even without the growth with respect to resources, fewest beds per capita, fewest physicians per capita, which means that we have a heavy reliance around making good decisions with good data. And so the AI journey for us is just starting. We are just in the midst of developing a new Epic platform that we'll be going live with in October. And so much of the conversation today for us is one of education, but we are planning on implementing Epic's Nebula environment, which is an environment that makes the health information system AI ready. And so there'll be a number of AI applications that we'll have access to. And so before that, though, in sort of the time we are right now, there's a few pilots or dipping of our toes into AI, particularly around developing a predictive analytics model to support discharge planning. So based on somebody's health conditions and history, here's what we think the length of stay is for that patient, and we can generate that a few hours after admission. And so that's one application. And then we've partnered with a vendor, and forgive me, I don't know the specific vendor name, but our medical imaging department is leveraging AI to support the workflow for radiologists to look at images and then, again, support the radiologist workflow to identify findings that need a closer look at, and again, speeding up resulting time particularly for our emergency department patients. So just a few examples and a little bit about Osler.
I'm Dr. Victoria Chan. I think I met a lot of people last year. I'm the Deputy CMIO at Mackenzie Health, and our hospital implemented Epic in 2017. So this is our 8th year of it, and we've had a lot of lessons learned. But I actually just Googled a few things. We've been using artificial intelligence in clinical workflows for a long time without knowing it. Our ECGs that we read, the electrocardiogram that we do of the heart, actually is an AI reading, and then we go and verify it. And then the automatic defibrillators that you see at tennis courts and gyms and apartments are actually based on AI algorithms reading the rhythms. But at our hospital, we dabbled in it in the analytics department, predicting respiratory infections and how many beds we would need. I remember in 2022, our CEO said, okay, so we're getting peds infections. So Victoria, how can your department predict how many beds we're going to need? So in context, we usually need 4 pediatric beds on any given moment. So I said to the CEO, we're going to need exactly 16 beds by December 15th. So on December 15th, we actually occupied 15 of those beds, so I was quite proud of our team for doing it quite accurately. We dabbled in the deterioration index that was available by Epic, and also our EMR has more than 10 predictive models. But our barriers actually have been the human factor, and people worried that we're going to rely on the computer, and what about whose liability it is, and will it be accurate enough? And then I think part of the barrier is actually literacy in data and literacy in artificial intelligence. I think there's a lack of understanding of what it could be and what it could do for us. And then finally, doctors have been using AI Scribe, and you've heard all about it. I think Heidi Health is here. And there's been a lot of, oh no, what's going to happen? Are we transporting data into the cloud? Are we just recording patient conversations without asking them? So a little antidote, I took my little kittens in for their first vet visit about 9 months ago. And she said, oh, is it okay if we record this interaction for my transcribing purposes? And I was thinking, wow, we're doing it in the vet office and we can't even get permission to do it in the hospital. So.
Yeah, no, it's I have stories to share about that too. And sometimes I argue that our pets get better health care than we do, because and partially perhaps because we pay for it. That's another whole conversation. But anyways, let's leave it for, we're going to let Michaela introduce herself.
Thanks, Jonathan. My name is Michaela Banning. I'm the Director of Product Management with Unity Health Toronto. So I work within the Data Science and Advanced Analytics program at Unity Health. You can think of us as an in-house AI shop for the network. So our group has all the skills required to actually build AI products and deploy them at St. Mike's, St. Joe's, or Providence. We've been doing that since 2018, and so at this point I'd say we have deployed around 50 plus AI solutions, AI or automation solutions into practice.
Okay, so the first question is, and maybe it's, because I think there's a lot of people out here today, and so it's funny, a lot of people look at the private industry and say, oh, you're moving so fast, you're not, but it's not true. We're being very cautious around this adoption of what I like to frame as augmented intelligence, because I think it's a lot more than artificial intelligence. Maybe share with us, and we'll do reverse order, one tangible project, and it's kind of the successes and perhaps pitfalls and challenges you faced.
That's a really good question, Jonathan. So maybe I'll start with one of our flagship products is called ChartWatch. So it's an early warning system that tells clinicians which patients are at highest risk of deterioration, so going to the ICU or dying. That problem context came to us from a physician on general internal medicine that was like, of all the pain points that we're experiencing, this is the one where we are motivated to solve, and we feel that if we can solve this, we'll have tangible outcomes, improving patient outcomes at Unity. So we went on this development journey with our clinician partners, and we co-developed not only the model, getting important insights from the clinicians on which variables we should be looking at, what data is important when you're thinking about deterioration of this particular patient population. And then they also were our co-designers in the intervention. So how do the clinicians want to get alerts when we identify patients who are at risk? Also, most importantly, what is their tolerance for false alarms? So we actually were asking those questions at the very beginning of the process because we knew from the clinicians, if we weren't as good as for every 3 alarms, 1 is correct, there wasn't going to be uptake. There's just so much alarm fatigue happening right now, and there was even products on the market, other early warning systems, that for every 11 alarms, one would be right. Some even require manual data entry, and it was just a burden that particular department, and I'm sure many people can relate to this, just can't take on. So we were able to build the solution and hit the threshold for alarming. We capture about 60% of deterioration cases. For every 3 alarms, 1 is a true alarm. And because we did the co-design with the clinicians, we came up with an intervention that were embedded seamlessly into their workflows. So wasn't kind of adding new processes or really putting out different care providers with trying to manage this new system. So in terms of some of the challenges that come along with that, you really have to be partners in the development process end to end with your clinicians. That was like a very important learning. And then when you're also, another important learning that we really take to heart is you can't just deploy these things and walk away. These projects are producing products that you then have to go on to support in an ongoing way. So you really need to be monitoring them and supporting them in a longitudinal fashion, and also be prepared to take them offline if you're seeing problems with those products.
And the current status is?
It actually had to come offline when we made a switch over to Epic in November 2024, and we've successfully relaunched it with net new integrations into Epic as of November 26, 2025, so 2 weeks ago. So we're still kind of making our way through some bumps in the road, but we are.
But it is live at Unity, so you go
It is
into
live at
Unity and
Unity.
it's going to potentially flag for you degrading patients automatically.
Yeah.
That's awesome. I dreamt about that when I was at a hospital. Okay, Mackenzie, you're up. Mackenzie Health. One better or what?
No, I'm not going to do one better. So we use the deterioration index that came from our EMR, and maybe this is the opposite story. So our team studied it. We put in the 17 variables that was supposed to feed into this model. It came from a large language model, a machine learning model, and then it spit out these 17 variables that feed into a deterioration index. So we did the whole analysis, the receiver operating curves, and we found out the thresholds for us would have been, thresholds don't matter, 40 and 60, and we were doing red, yellow, green. So during COVID, we actually piloted it by showing the doctors the score on the patients. And the way that we used it was, so I'm a physician, and when I come to a ward, I don't know which patient to start with first, so I would just start in a clockwise fashion, go from room 1 all the way to room 19, or whichever way, or even reverse order, and then I would figure out which patients are sick and which ones aren't. So when we deployed this model, I looked at the high-risk patients first, and I went to those rooms first, and then I went and rounded on the less risky patients. Out of the high-risk patients, I remember when we launched it, it was during COVID. And if you remember during COVID, people didn't know that they were sick and they didn't know that they needed to call for help. But this model actually detected really subtle things in their lab work and also in their vital signs that we couldn't detect clinically. Because if you've been a clinician or a nurse for a long time, you know when someone looks like crap and you need to go to that person first, but this deterioration index would actually tell us that. So out of the 5 patients that it flagged, 4 of them ended up going to the ICU before the end of the day. Well, the use of that is that I didn't go and come across that patient randomly at 2 p.m. I saw them all between 8 o'clock and 9 o'clock. So much better for the patients to be sorted out at the beginning of the day. Well, what happened was, because we didn't develop the model, we just kind of put it out there after the analytics team worked on it, there was major skepticism and also resistance to putting it out widespread. How are we going to use it? What happens if we miss someone? Can you look at this person who died? Can you just sort of show me all the deterioration index scores leading up to that death? It turns out at our hospital, the critical care response team was doing a pretty good job. And so because we've been doing a pretty good job for 25 years, why do we need this AI model at all? And so we went around in circles, and then Health Canada shut us down last year anyway, and then redeploying it again. So I think the lesson is, I think Michaela's point is really well taken, that people have to get intimately involved in the model during the development and to actually even educate themselves and gain understanding of the new tools. Like, I drive a Tesla, but I'm not relying on the ultrasound and the cameras. It's just augmenting my driving experience. If I get into a car crash, it's still my fault, right? It's not Tesla's fault, unless I put it on total full driving and I fall asleep at the wheel. But
Your fault.
But then is it still Tesla's fault? We can debate that,
It's still my fault for falling asleep.
perhaps. Okay, yeah, Deepak, tell us about McKinsey. Or, sorry, no.
Yeah, Osler.
Osler.
So I think what I would sort of start with Osler is we had some ideas for AI and where we could adopt it. Again, I mentioned the predictive model for the estimated data discharge. But before we deployed, and then the medical imaging opportunity with a vendor, even with those ideas, we decided we wanted to have a policy first. And so we got a group together to really think about what our principles, and again, it's not like a detailed policy that you would anticipate, it's fairly simplistic. But what it did do is it set down some ground rules and some groundwork to say, fundamentally, what we do, to Victoria's point around accountability, the adoption of AI has to be augmenting decision-making, not the shift of any sort of accountability. And we need to be very clear about that. It may be easy and assumed by clinicians, but we want to make sure that that's embedded in policy, that everyone understands that if we're sort of making some information available or a tool or a workflow available that's supported with AI, that fundamentally that accountability still rests with the decision maker. And so I'm not going to speak a lot around the AI example with medical imaging, but I will talk a little bit more just to Michaela's point around design and approach. So we did our IT folks, we have a brilliant person in our IT department that he sees things at conferences or, a VP comes back and says, why can't we have this? And he says, well, I can just build it at home. So don't go and get the GE command center from Humber River. Sorry, Humber River, I'm not trying to lay a dig or anything, but we'll just build our own, right? So that's kind of the culture of the organization is why I raised that. And so similarly, when they saw the predictive model that Unity had developed with respect to estimated data discharge and then the partnership with Signal One, we said, well, we can just do it ourselves. And they went ahead and they did this work. We said, well, how do we know it's accurate? And so they said, well, we have a metric. So what we'll do is we're going to say, what's the percentage of agreement? So when did somebody actually get discharged and what did the model say? And then, we'll report to you and it's 90% accurate. Now, of course, in the decision support space, when we have IT give us something like that, we're like, can I understand what your methodology is? Well, they were updating the model on a daily basis. Well, if you're updating the model on a daily basis, well, of course you're going to have 90%. Why isn't it 100% at that point? So I do think, that partnership, that sort of human workflow integration, and then that ongoing support to make sure that, we're developing and deploying models that are actually creating efficiency. And that they're meeting the workflow and the business need, and that the business, the clinical leaders, are able to feed back, and that any sort of iteration that's happening is happening in a very transparent way.
Maybe as a derivative of that, you mentioned a policy in place, right? And you talked about a group of people. Define for us a little bit more. Like, who was that group?
Yep. So physician leadership. So we had we have a quality lead. He's actually now our chief medical information officer, but at that point he was the organization's physician quality lead. The CIO from technology lens perspective, a couple of clinical VPs, and then me from an organization strategy perspective. I think privacy. Trying to think. I think that's probably the bulk of the group. It was a fairly small group. And again, we then leveraged, who did I miss, Andre? Oh, yes, and then practice, professional practice. Thank you. And so, yeah, that was the group that came together, and then we leveraged our executive team just to make sure that there's oversight, and then we have a clinical senior leadership team that's every clinical leader in the organization that we often use to bounce ideas off. But a fairly small group to work through the policy implications.
Victoria, did you say you were shut down by Health Canada?
Yes.
Tell us more about that.
Is Health Canada here?
Probably, but that's okay. We're here to learn and share. What happened?
Okay, so the controversy was
that was a surprise question, by the way. She doesn't know how it's going.
So the controversy was that Epic, the EMR, marketed this tool as an artificial intelligence tool. What is AI? Like, we could get into that. What is AI? Does it learn? Does the model learn? It actually was just based on a big, massive cognitive computing model that they ran 400,000 patients through, and then they identified through just fancy logistic regression which values actually feed into deterioration. And so 17 variables bounced out of this, and then so there's a score, and then you're supposed to do your receiver operating curves and your positive predictive values and sensitivity analysis, et cetera. But Health Canada said, if this is a machine, a medical device, then are you guys standardizing it with all of the other hospitals that are using deterioration index? So everybody just stop using it until we have a greater understanding. So the CMIO table and the CIO table worked with Health Canada to increase that understanding, and now they're allowing it. And then there was an appeal by the EMR, and now they're allowing it again. But really, the deterioration index is no different than the falls risk score. There's LACE scores, and there's other scores for dementia, for delirium. And those scores are actually way less sensitive. And to your point, the other day you were saying the computer has to be 98% correct, but humans are maybe 60 to 80% correct, and we're okay with that. So case in point, every time we looked at the deterioration index, our CCRT was already there. Well, guess what? Probably our CCRT, our critical care response team, is seeing too many patients. They're probably overworked, and they're trying to do this giant net so that they don't miss any sick people, because the fact that they're catching every single one and maybe people who don't even need them, I think that AI or this augmented intelligence, your term, maybe you'll change the world, Jonathan.
Well, actually, it was Jim Swanson from J&J who started that phrase, but
Maybe it will actually reduce the workload of our CCRT, because as our hospital grows, we can't keep monitoring all the sick people across different sites to the same standard.
Or maybe we even monitor them at home.
Maybe.
We could talk to VHA this morning, right? Michaela, you talked about your project was intense, right? It sounded like a lot of time, a lot of resources. Mm-hmm. Tell us about that. What did you have to do to convince the organization to put this type of resources into this?
Well, one thing that I think...
Oh, and a question before that.
Yeah.
Did you start with a policy?
Did we start with a policy? Well, I think one thing that's really important about Unity Health Toronto is we've named AI as a strategic pillar. So it's something that the organization has made a commitment to invest in. So I think that piece right there is really important, because like our group, in order to build the things that we do, you need a diversity of skill sets. So we have, in my portfolio, it's product managers, clinical informatics specialists to really facilitate project management and that change management piece. You have your data scientists who are actually doing the models. You have you have data engineers, system administrators that are building the data pipelines, supporting and building the internally hosted infrastructure, and then you have our product developers that are building the front ends that clinicians interact with. So, I mean, that costs a lot of money. Mm-hmm. It's something that Unity has chosen to do. And in terms of policy, like how do we do the work that we do? So one thing that helps us is everything that we do is under the umbrella of quality improvement. So because of that, we don't need those Health Canada approvals for these solutions that we're building and deploying in-house. And the other thing that really helps us is the relationships that we've built along the way. So we have really familiar and friendly relationships with our ethics leads, with legal, with privacy, and we work hand in hand, and with security and IT. So we really work hand in hand to make sure that we're doing things safely and kind of checking all the boxes within all of those other departments, so that we can continue to work and grow together, like in step together.
Okay, so let's look into the future. Mm-hmm. We're talking about, say, 2 years from now, 2027, Christmas time, 2027. What does your organization look like then, as opposed to where it is today along this journey of AI and adoption?
It's a really good question. I think for us, it's always just kind of pushing the envelope in what we're developing. So really looking at tools that are multimodal. So one thing that we're looking at is how can we tap into waveform data, so like the data that's otherwise locked away in telemetry devices. How can we be leveraging that with our tabular data and text data to really make a difference in patient outcomes and healthcare system efficiency? I think that's and then it's just continuing to develop our relationships across the organizations, because the best tools are solving real problems. And the people that are best at identifying the real problems are the people on the ground experiencing them directly. Those are where you get your best solutions. And so it's fostering those relationships with like the people on the ground that are going to have the best ideas, and making sure everyone's voice can be heard and the best ideas can kind of bubble to the top. I think it's kind of breeding that culture of innovation organization-wide so that we can facilitate the next gen of AI tools in healthcare.
It's kind of an archaic example, but when you're talking about the simplest things sometimes, right? Coming from the front lines can solve the complex problems. I remember we had a challenge of wait times, ambulance offloading, and it was literally taking a stamp that had a date timestamp and stamping a piece of paper. I mean, we're talking a decade ago, but at least we had an accurate record of that timestamp, right? And so we just, by implementing that practice, it changed the data, and of course it changed the outcome of the whole wait times, or in terms of offload times, because then we now had accurate data. And stuff like that.
Sometimes it's the most pragmatic ideas have the biggest impact opportunity.
Do you have one you want to share?
Okay, one of my favorite stories is we had one of our team leads from the emergency department. So one of the RN managers came to us and was like, I am spending hours a day assigning nurses to zones in the emergency department. And the reason it takes so long is because nurses generally don't want to be assigned to the same zones over and over again. You don't get the variety that moving around, like the training opportunity that moving zone to zone gets you. And then some zones are less desirable than others. So, getting stuck in acute shift after shift after shift can be like really tiring for some nurses. And there was also a level of subjectivity that was happening too with assignments. So there would be a lot of complaints of like, well, she keeps getting assigned to this zone with her friend and it's not fair. So how can we take this very manual and stressful activity and scale it back down to like automate it in some way? And so after some consulting with our data scientists, there was an opportunity there to build an optimization model that you could feed those schedules into, and it would just automatically pop out your assignments with the goal of minimizing repetition. And the development of that tool took the team lead time spent on doing those assignments from 90 minutes a day to 15 minutes. And then, to 30 seconds, because to do the assignments was just pushing a button. And the admin assistants that were doing all the daily schedule preparation that feed into the assignment tool, their very manual process went from around like an hour and a half today to 15 minutes, because the tool automated some of their process as well. So it's just like, it seemed, and the other thing that was so surprising to us, because it's such a straightforward idea, is like this obviously exists on the market. There's so much scheduling software. Of course someone's come up with a assignment automation add-on, but it didn't exist.
Yeah.
So.
Interesting.
Jonathan, can I?
Yeah, of course, jump on that.
So, a couple of things. So there's
And also
things.
tell us what your hospital's going to look like in 2027.
Sure. Yeah, that's I'll touch on that as well. Just on the nursing assignment piece, Jonathan mentioned HBEM in a sort of a joking way. I don't know if people sort of know that we don't have a funding model right now. It's been shut off for years. The ministry would say, yeah, we do, but we don't. It's silly. It's silly what they do. Nevertheless, hopefully people have heard of things like weighted cases. Weights are determined based on case costing data. Case costing data assumes, unless you're in one of the maybe 5 or 6 hospitals in the province that still do nursing workload, nursing being one of our largest costs. So if you're not doing workload and reporting it specifically, we're basically averaging out nursing costs equally to every patient, which means the weights are, excuse me, I swear, bullshit. When we think about what we can do with AI, think about the opportunity when we can start to get better nursing documentation and what we can build upon that nursing documentation to not understand nursing workload. We're not trying to pick on nurses, but to understand the differences in patients and their criticality. So, vision for the future from a system lens perspective outside the organization, I think we're clueless in terms of what costs actually are in hospitals, and I think having some of these more sophisticated tools becoming available to actually understand what our cost structure is will really help us fund the system and behave as a system, as opposed to what we're doing right now, which I can't figure it out. I think it's going to have, beers with Doug is really what's driving funding these days. So just one other point just around the future. So two things on that front. What do I think OSER looks like from a future perspective? I kind of wrote down a buzzwordy type thing. I think where we're going to be is the cognitive burden should start to decrease. So that's where I think AI is really going to help us for the clinicians and the cognitive burden that's on those clinicians, that we find the right balance between having tools that reduce that cognitive burden on those clinicians and decision makers while still not getting to the point where there's an accountability challenge. So the accountability is still clear, but we're going to give those tools available to make the job easier while still understanding that fundamentally the care provider, the decision maker is accountable for the decision, even if it's augmented through AI. The last thing, though, that I wanted to sort of share, sort of elevating that and, again, putting a systems hat on again, what I worry about and what I think some of us really need to worry a lot about is Unity, Mackenzie, Osler, we're GTA hospitals. For whatever reason, we're in opportunities where we can spend money on some of these sophisticated AI solutions. I don't think that's equal in the province. And so when we think about the challenge that we're already facing from an equity perspective, how that's going to magnify when we've got these tools to alert, this person's about to code, is that tool still going to be available in other parts of Ontario and then more broadly the country? So I think that's the next horizon from an equity perspective is access to these tools.
Yeah, and how we share it right across the stuff like that. I'm going to ask you a very pointed question before we get to Victoria, but can anybody here email you and say, hey, tell me more about that? Can I have that policy? Can you share that? Sure. Yeah. And that's been my experience. When I worked in the hospitals, it's amazing. People are like, oh, I can't email, Deepak, he's the vice president. I'm like, he's happy. It might take him like 5 days to respond to you, just for the record. But absolutely.
5 weeks.
5 weeks. He doesn't use Microsoft Copilot as much as I do. But anyways, Victoria, tell us about Mackenzie. What's it look like in the future?
So in the future, well, I'm going to go back in the past. So 30 years ago, I'm older than I look. 30 years ago, when I started, there was a small hospital which is now closed, but we had a telemetry nurse whose sole job was to look at all the monitors in the hospital, and if anything happened to any of those patients, she could call a code from the ICU. Well, restructuring District Health Council in the late 90s and even current day, there is no telemetry nurse in most hospitals. But we put monitors on everybody, and actually those monitors define what is an ICU bed, what is a step-down bed, what is a telemetry bed. Oh, we have so many monitors in the emergency room. Who's watching the monitors in the emergency room? We are actually putting the monitors on. No one's watching those monitors. We're relying on the artificial intelligence algorithm of the ding, 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 and the papers spewing out. So I see a day where if we did have monitors, or even those patch monitors that technology has now, we could just put it on a patient. I mean, it's on a ring now for patients outside, for people outside. Can we have monitors that really give us meaningful data and decrease our cognitive load and make us concentrate on the people that we need to see the most, instead of burning us out by having to see all 30 of them because we just don't know which ones to focus on?
And to your point, Victoria, I think one thing that has to go hand in hand with all of these AI tools and AI deployments is the intervention piece. Like, we can't just turn all these things on and expect healthcare to get better. Yep. They have to be paired with very smart interventions that integrate into workflows, that people actually use these tools, and we get the benefits that the best potential we can out of the possibility.
Well, and
open
let's
up.
be honest. I mean, the hospital is the last place where we want people to end up, right? What's the role in prevention, right? And getting, we were having a conversation earlier with a physician here, right? And talking about public health, right? And prevention and the use of AI algorithms and embedding it in there and stuff like that. I'm actually going to turn to the audience right now. There must be some questions out there. Anybody have a question? Oh, okay, we got one here in the front. We're just gonna get a mic runner. They'll be up there in a second. I think that was the physician I was talking to earlier from public health. Oh. Maybe if you could, I got to introduce yourself and where you're from.
Thank you so much. My name is Hasib. I'm trained in the US. Somehow I couldn't find myself fit, and then I turned to public health. I completed my master's and PhD, so I'm a physician in public health, doctor. When you are using, some term, we have to be careful, like policy. Sure. Policy is, is the job of the government. There are other, document, we can call it guideline, protocol, and reference document. So guideline is, how to approach a standard operating procedures. Protocol is how to operationalize a standard operating procedures. And reference document is, you cross-check those standards. So, and the way you know that the AI is progressing, it could be, devil, it could be an angel. You might be aware of, like Elon Musk is working on perpetual humanoid, AI. A battery for 500 years, replacing human. And there were, some experiences that they put, chip on the brain of, a psychologist, and they transfer all those data, put it on a child, and that children have all those knowledge. So it could be, humanly used, or it could be used for the purpose of profit. Now, my question is, you say that, you use models. These models, the way that these models are working, it is, embedding the information, tokenization, reflection, prediction. Prediction, not confirmation. Have you, run your model at least, 5 times that your model find the same people? Because every time that you run the model, they will give you more different prediction.
Okay, so I'll paraphrase. Oh, so is that the question?
Yeah.
Okay.
My question is, the model that you are using, is it cloud-based or it is in-house infrastructure-based?
Okay, so first question is infrastructure, right? Cloud or not cloud? Having worked at AWS in the cloud division, I know that answer, but we'll let you guys answer it for yourself. And then 2 is, how do you know, like, these things, like, how do you test and how do you give confidence to the people who are relying on these algorithms to trust them? Maybe we'll start with Victoria in the middle.
Well, we actually did the deterioration index within Epic, our EMR, because it was one that could be run on-prem, because we're not on the cloud. And we started way back in 2015, 2016. So at that time, cloud technology and the infrastructure and everything wasn't really there. So ours was on-prem, not in the cloud. And I think the word cloud is just this nebulous, nebula, whatever, this nebulous thing that everything up there is so great and all the data architecture is there. There can still be a mess up there in the cloud, right? So are you guys on-prem or on the cloud?
Yeah, so our infrastructure, it's all on-prem, on the trusted network with encryption between all of our systems, like the way data moves through, it's all TLS encrypted. But I mean, like future looking, we're future looking at a hybrid environment where we leverage the cloud as part of, in addition to our on-site infrastructure.
So
And then going back to how do you get trust, how do you build that trust with it too?
So an important part of all of our implementations is monitoring. So as part of your deployment, setting up that monitoring, so you're monitoring the data that's going into the model, you're monitoring the model performance in an ongoing way, and you're also monitoring how that product's doing live in the world. So you're following up with your stakeholders, are people using it? You're checking to see is it giving the desired effects that we expected it to have? Monitoring has to be kind of part and parcel with any of these deployments. It's not just a deploy and walk away.
Deepak.
Yep, no, so very similar. Again, we're dipping our toes, so so we're on-prem, and then there's we run the model multiple times. We've got 30 years of data there, so we can sort of segment out different data horizons and test the model in a variety of different ways. And then from a deployment perspective, again, it's not a model that's simply taking action on its own. It's augmenting and supporting somebody in a decision. So if a clinician looks at it and says, yeah, there's no way that discharge date would be feasible, then override it.
Question right there.
Thank you. First of all, thank you so much. That was really a great discussion panel. It raised lots of questions. But one of my main questions was, how do you address the fairness of your model prediction? So we're in North America. We're living with lots of marginalized population or rare disease. So we may not have a balanced data set for that kind of sectors, maybe. So not enough symptoms is detected for those rare disease, not enough parameters or variables is detected, so we don't have enough information to use it and predict. And how we are checking, of course, the model, for example, for lots of known disease is predicting really well and going toward that prediction really accurate, but what about if it's a rare disease or we don't have enough balanced data set about how is your model addressing that?
Good question. Go ahead.
I can start, and then Michaela might have a better answer, hoping. So part of our rationale for dipping our toe and going slow and not getting into specific diseases in terms of anything that we've started at Osler is for that exact reason. The sample sizes with respect to just having enough data to have an accurate model, clearly we wouldn't have that as much as it's a lot of data that we have. The opportunity that we have with Nebula, though, is that it's giving us an environment where it has all the Epic hospitals. So that's an international company. We're talking about hundreds of millions and billions, and I probably couldn't even say the number large enough in terms of access to individual patients from a data set perspective. So I think it gives us access to more data. Now, again, we've got to sort through what that means from privacy implications and anonymization and all those pieces, but in theory, a model can be built in a privacy-protected way that could be leveraged by many, and so that's what we're looking forward to as we get into the Epic Nebula environment and what sort of tools that provides for us.
It's a really good question because when we explored the model, one of the predictive models inside Epic is the likelihood of admission. But the likelihood of admission depends on a lot of social determinants of health that the hospital doesn't collect right now. You guys collect it, but we don't actually collect it, or we're not integrated with public health data to know if that person came from that postal code, what all those social determinants of health in that postal code are affecting that patient. Same with likelihood of missing an appointment or no-show, those are determined. So some of the models that we looked at implementing, we were limited because, number one, we're on-prem. Number two, it depends on what kind of data that we're collecting. So we chose the deterioration index because it was 17 variables that were lab or vital signs or something that we would collect. And even then, the rapid response team in the States is very different. So at the beginning, one of the skepticisms we had was the model was based on Americans. So we're Canadians. But one big thing about Americans and Canadians, we have not Medicare, but we have universal health care, which probably makes a huge difference based on that data model where that model was developed versus what we have here in Canada, which is universal health care.
Any thoughts?
Just want to preface, I'm not the director of advanced analytics, so I can't go very deep here, but I can talk about our process. Standard process for us is we have a model fact sheet. And one of the sections of that model fact sheet is we do assess for bias with the data we have available to us. So we can assess for bias in terms of age, sex, but ethnicity is not something that's collected regularly, I think, across most institutions. So even though that may be like an important area of investigation, it's not something that we can really do easily. And I do think there are steps being taken to start collecting some of that more sensitive data, but it's not an area we've really delved into. We have, I know for our ChartWatch model, we did do work to look at bias in terms of socioeconomic status using postal code. So there are things you can do to look at that, but it's not something we can do for every implementation.
Yeah, I think there's a lot of innovative data. So I know, Deepak, you and I worked on a project about 5 years ago, I think, about how a hospital could access, different sets of data that perhaps they wouldn't necessarily have. And so that was some pretty cool work that we had done too. So
Community pharmacy, right?
Yeah, and I think that's where don't ever think that the data's out there. I think we can all agree, right? I think that, and that's an important part about today too. Like the data is out there. So going back to your point earlier, right, is that let's not be afraid to share it, and how do we share it and stuff like that. Any last questions? Oh, over there. Oh, we got two. We could go over by a couple of minutes. We got one question over here and then another one over here.
Okay, I'll go ahead. Omar Dowdy, I'm the Director of Data Governance at GreenShield. And I had a question regarding how you ensure that the use of data and AI is being done for the purposes that it was meant to be used for, primarily, let's say, to protect against inappropriate use of the data or the AI, and also some data loss prevention techniques if you employ any of them.
Sure. Again, at this point, we're following the hospital's existing policy guidelines, and so we rely on that sort of confidentiality. And again, any of the deployments that we're looking at there's a lot of oversight over them in terms of the number of leaders involved. So at this point, it's not sort of so pervasive that that risk is significant, though the risk with respect to protecting, being a good health information custodian and protecting privacy, it's the same risk. At this point, it's not a different or a new risk, so we're relying on the same infrastructure.
I'll give an example. One of the doctors was worried about us using a deterioration early warning system. What if the patient can see it through their MyChart and then I missed it? What legal liability do I have of that? Even when we're doing this data review and we're looking at the cases where someone had a bad outcome, what was the deterioration index scores leading up to that bad outcome? Even the validation, we have to really be careful about anonymizing that data because it can be used for not bad things, but medical legal purposes, right?
Oh, absolutely. I guess we'll take one more question. We'll see if we get two, but there's two questions still. There's one over here and then one in the front. We're now over time, I'm being told.
Excellent. Simon Higgins, a consultant and researcher, and love this discussion. I wonder if we can go back to a comment you made, Deepak, which was about spread. So incredible capacities you have in your organizations, but many healthcare organizations across the country aren't going to have that capacity. What can governments, what can organizations like yours be doing today to make sure that those other organizations that are just trying to hold things together cannot fall too far behind in this process?
Sure, it's a great question, and it's why I raised the topic, because I don't know. And so I thought I'd raise the topic in a room full of really bright people to say, hey, this is going to be a problem for all of us, where there's going to be, again, as I stated, another equity challenge where some will have access to a better health system than others. And so I think government's woefully sort of behind, and I think these conversations and these conferences hopefully will stimulate some more conversation and a greater focus on governing AI. And again, it's a societal issue as well, right? There's the healthcare part of it, but from a societal perspective, there's lots of fear, and you got Health Canada shutting down a hospital just because they heard the phrase AI. So it's not that they're not paying attention. I think they just don't know what to do at this point.
I think technology might take us there, because our EMRs right now, where everybody has their own instance and we're starting to consolidate them, but I think technology might take us there. Maybe it might become more universal and it can be used up north.
Yeah, well, it's so funny because technology used to be a barrier, and I was laughing at Infrastructure Ontario. Sorry if anybody's from Infrastructure Ontario, because they were literally laying high-speed cable internet up where I'm fortunate enough to have a cottage. I grew up in a very small rural area. Meanwhile, I have one of those Starlinks, which is pulling down like faster internet service. I'm like, why are we running high-speed cable? Let's just go buy everybody a Starlink. Like it'd be way cheaper. But so I think technology can get us there, right? I saw Rogers just announced satellite phone, right? One last question to close it up for our group here.
Yeah, I was also curious when you mentioned the equity with AI tools. And across the province in Canada, the hospitals, many organizations are on different stages of their AI journey. And for those looking at developing or accessing these tools, can you compare and contrast the developing an in-house team for these AI solutions versus exploring the external products and how that might look?
So we'll make it really quick. Give me a ratio between in-house versus external as a percentage.
I still say half and half just because I don't have a better answer.
50-50.
I think you got to do both. Yep.
So we're a build shop, but I think that there's, but a lot of places are buying. And so I think it deserves just as much attention to think through what are our processes for buying these solutions as much as it is how do we build in-house. One thing that we put out this year was Health AI Academy, which is academic program for health leaders to kind of teach them how to do AI implementation, whether you're building or buying. And so I think accessible education to arm people with the knowledge to think critically about what AI solutions they're bringing in-house, and to do that in a way that's equitable and making sure that you're solving the right problems that are going to have measurable outcomes.
Sorry, what was the name of that again?
Health AI Academy.
Health AI Academy. So we Google that, we'll find that
Yes.
at Unity?
Yeah.
Okay, fantastic.
Well, yeah.
Sorry, go ahead. I don't want to cut you off, Michaela. Go ahead. You were going to say something?
We just finished our first cohort, so assuming funding can come through, we can still make that education freely available to help national or healthcare organizations bring in some of this tech in a way that works for them.
Perfect. Close it up for us, Victoria.
Analytics maturity. I don't think you'd be ready for AI until you actually march your organization up an analytics maturity model. You can use Gartner, you can use AMAM, but I think if we get there prematurely, you're going to be modeling off dirty data, stuff that's not relied upon. So I think my hospital, as much as I'm on all these platforms and everything, I don't think we're there yet either. It's like a widespread understanding of data usage, data analytics, the literacy, et cetera. I think there's a lot of work to do. And then we can get to AI, because I think you're teaching, grade school students university calculus. I don't know if we can actually get there that quickly, not the whole population anyway.
Perfect. Thank you. Big round of applause for our panelists. And again, they are available for questions. So we are moving now into our morning network break.